Good afternoon and welcome to this month's Northern Virginia Health Policy Forum. My name's Jim Scott and I'm the president of Applied Policy based in Alexandria, Virginia. Our focus at Applied Policy is to help healthcare organizations navigate the complex world of health policy, and today we're going to talk about coverage, coding, and payment. So we're pleased to host these monthly gatherings in order to share information and exchange ideas on an emerging and important health policy issues like Medicare coverage of innovative technologies. Today, we're honored to host Tamara, Syrek, Jensen, and Jason Bennett from the Centers for Medicare and Medicaid Services, where I used to work a long time ago, to discuss promising opportunities to modernize U.S. healthcare. And the opportunities I'm referring to are the explosion of new technologies and advancements connecting the physical, digital, and biological worlds. These new technologies have the potential to rapidly improve the value of existing products, the work of healthcare professionals, and the lives of patients. Our guest today will address the steps that CMS is taking to bring these technologies to beneficiaries more quickly through innovative reimbursement structures. Ms. Jensen is an attorney, and she's the director of the Coverage and Analysis Group at CMS. Insiders call it CAG. She leads efforts to develop, interpret, communicate, and update evidence-based national coverage policies. These policies are designed to provide timely access to reasonable and necessary services and technologies to improve health outcomes for Medicare beneficiaries. And Ms. Jensen is joined by Mr. Bennett, the acting director for Technology, Coding, and Pricing Group at CMS. He provides executive direction for the consideration of new technologies and their treatment in the Medicare program. Additionally, he leads the development and evaluation of national Medicare policies and standards on certain benefit structures and payment methods, the maintenance of medical coding systems, and the assessment of applications for special consideration for new technologies under several payment systems. For example, the hospital outpatient department prospective payment system has a pass-through payment application. Thank you all for joining us today. Let me get started with the questions, but first, I'd like to congratulate Jason Bennett. Breaking news here today. He used to be the acting director, and now he is no longer the acting director. So he's fully installed in his leadership role at CMS. So congratulations, Jason. So, so before we get started, I was hoping that maybe, what I hear a lot about is Medicare reimbursement consists of coverage, coding, and payment. And so those things are different. And so I was wondering, Jason and Tamara, if you could start off by telling us a little bit about what your role is and what does, coverage mean and what does coding and payment mean? And let's go to Tamara first.
Thank you. And thank you for inviting me today. I appreciate the opportunity. I don't think I have been at this meeting before, so very much appreciate it. So I think Jason and I work together very, very closely. And so what I usually say for fee-for-service, traditional Medicare only, that everything is in our world, it's like a three-legged stool. You need to have a code, you need to have payment, and you need to have coverage. All those three things work together. And there are a lot of different avenues in how you get there. So for coverage specifically, there are at least three different pathways that you can get coverage for your particular item or service, device, drug, biologic, anything else that fits within the Medicare statute. And you can either do it claim by claim adjudication, meaning which many things do. You just submit a claim and it goes through the system to see if it's being paid or not paid. Or there is a local coverage determination, which are various Medicare administrative contractors, our contractors across the United States can write a coverage policy for their particular jurisdiction on whether they're going to cover something, not cover something, or under what circumstances they may cover something. And then if for a national decision, and many things are either at a local coverage determination or claim by claim. So for a national decision, which we can do anywhere from, we do 3 to 5 a year, that similar to a local coverage determination, we make a decision on whether to cover or non-cover a particular item or service. And more often than not, when we walk through a national coverage determination, it's really under what circumstances would we cover that particular item or service. So what specialties, what place of service, perhaps the frequency, which patient indications, those types of things are what we would do in an NCD. And then the process for a national coverage determination and the process for local coverage determinations are all outlined in statute, and for NCDs also in a Federal Register notice. They both provide opportunities for public comment to weigh in on the policy we have. What's most important for any public comments that come in on coverage determinations is not only the comment, but also the evidence that supports why we need to change our coverage determination one way or another. And then for national coverage determinations, there is a time frame where we issue a proposed within 6 months of announcing we're going to take a look at a particular item or service, but we issue proposed in 6 months, 30-day public comment period, and then the final, which is effective on the date of publication of that national coverage determination, must be issued no later than 90 days after the proposed has been published for public comment. So let me stop there to see if you have any questions, or we want to move on to Jason and coding and payment and everything he does.
Thanks, Tamara. For sure, I have some more questions and want to unpack a lot of that, but let's go to Jason. And Jason, if you could tell us, what are coding and payment and what's your role with respect to them?
Yeah, thanks, Jim. Thanks for having me on. I think if you pulled my bio from LinkedIn, it's probably still dated with my old title there, so I won't fault anyone for that. So let me first focus a little bit on coding and give some perspective there. In the technology coding and pricing group, we have a couple different responsibilities on coding. And really what begins our analysis is the question of what is the appropriate HIPAA code set with which a particular product or service would best be described. And part of the reason I say that is because most individuals, when they hear HIPAA, they think of the privacy aspect, the privacy and security aspect, but there was also an aspect about the transaction standards and efficient claims processing. And this goes back to some degree, the start of electronic transfers and kind of pre-EHRs, and where Congress really envisioned this sort of design to have an efficient way with which healthcare claims could be processed and transacted kind of regardless of payer. So much of an analysis for coding for us is looking at it across the whole healthcare system, not just looking at it exclusively for Medicare. Though Medicare is certainly one of the largest payers, it's not. We're not the only payer, obviously. So one of our first analyses when we are presented with a question about a particular code is the product or service best described by a level 1 CPT code that the American Medical Association would have as part of its responsibility? And then if that analysis really is kind of concluded that that's not the code set, then we're looking more specifically at whether the HCPCS level 2 code set is the right code set to describe the product. And that goes into a series of analyses of whether it would typically be separately paid, whether it would typically be a healthcare service, just a number of questions along those lines, as well as very much setting of use. And for instance, part of the code sets that we work on are ICD-10 procedure codes, Our colleagues at the Centers for Disease Control and Prevention work on the diagnosis codes for ICD-10, and then we have the complementary procedure codes. And if the product or service is really only used in the hospital inpatient setting predominantly, for instance, it's probably best described in some respect by an ICD-10 code and would typically be bundled into a DRG for our hospital inpatient system. So there's a number of questions like that that we're really looking at when presented with questions about coding, which is first of all, what's the likely setting of use for Medicare or other payers? And would it typically be an item or service that's bundled or separately paid? And then we go into questions about how distinct is it from something else that may be already in the market and has a code then that describes it. So it's kind of a multi-step analysis for us in that respect. In terms of payment, it's sort of similar types of questions that you see there, but it's very much for us in terms of Medicare fee-for-service. It's driven by our statute. Our statute has certain requirements of what kinds of settings we can pay, whether it's a physician office or clinical office type setting, durable medical equipment for the home setting, home health, inpatient, outpatient, hospital, end-stage renal disease, and so forth. I think there's like 16 or so different kinds of payment systems across Medicare fee-for-service. That may be a low count. And then there's some separate benefit categories even that are part of those. So our analysis is very much beginning from what's the setting of use. And from that, then we assess whether again, is it typically bundled? Is it typically paid separately? And goes into the questions then about distinction. And a number of folks approach us sometimes talking about payment, really thinking that we're maybe entering into some sort of a negotiation. That's not really the methodology that we have. We very much follow a statutory and a regulatory methodology for setting and establishing payment across the system. And so it becomes a question of distinction and then what's the appropriate methodology to assess in terms of establishing an initial payment allowance that Medicare might have assigned to that service. And certainly with new technologies, that may adjust a bit, particularly in the work that I do. We work on inpatient new technology applications, outpatient pass-through, as Jim was mentioning, some end-stage renal disease add-on payments, and some others. And as many of you know, those systems often have a budget neutrality aspect to it. And some of those initial entries to the market are designed to collect and assess data and determine perhaps to what bundle they're assigned. And so all of that definitely probably explains why a group like this is formed, as Jim was saying, trying to kind of navigate the overall healthcare landscape, because I'm sure if that sounded simple to you, then you probably know more about Medicare maybe than I do at this point. And so, that I think we certainly understand that there's a lot of complexity here. And it seems like with every new piece of legislation, it's not getting easier. It's usually getting a little bit more intricate. So one individual I will mention who's not here with us today is James Bailey. James and Tamara and myself work very closely together. And James Bailey and his team are really an excellent first contact if you've got a new product that's coming to market, because what he will do is do an initial vet and discussion with you or your clients to try to understand what questions you're asking, what policies you think CMS may apply to your product for Medicare, and then try to bring together the right cross-cutting team. Because, for instance, if someone may say, well, this is a coding issue, but it's a payment issue, or maybe it's a little bit of coding and a little bit of payment, or it could really be coverage. And so it's important for us to try to figure out what's the concern or the question that's being asked. and bring that team together. And so I really would plug James Bailey as a good resource for you all.
Great. Thank you, Jason. So let me go back to Tamara, and Jason, we're going to come back to you and unpack some of that with some more specific questions about the different kinds of applications that your group reviews. But before we get to that, Tamara, there's so Medicare covers more items and services than there are national coverage determinations for, or even that there are for local coverage determinations for. So could you please tell us, like, when is a national coverage determination appropriate, and how does CMS decide to open the NCD process, and maybe some examples of recent or pending national coverage determinations would be great.
So the way that the statutes or 82L of the Social Security Act, if a stakeholder, and we don't define stakeholder, it can be anyone, a patient advocate, a patient, a caregiver, physician, manufacturer, you name it, it can be anyone that can request a national coverage determination, but there are criteria when you do request an NCD. And if you meet that criteria, which we outlined in a Federal Register notice, but it's generally you need to have, with your request for an NCD, also submit the appropriate evidence supporting that request, then we are obligated to open an NCD. The challenge with that is that we have more requests than we have people. And so some of these requests will be put on a waiting list, and the way that we will prioritize them is an impact on the Medicare population, Medicare patients. And so that's in general, we would handle a national coverage determination, or when we might open one. Now, there may be a very significant event that occurs, or the evidence is something comes out that requires CMS to open up an NCD without an internal request, or maybe we know that, or without an external request, or maybe we know of an external request that's coming, but we wanted to get the process started to move it along. And I think the best example and the most current example of that is monoclonal antibodies for the treatment of Alzheimer's disease, which we are in the thick of right now, where CMS opened that decision, but we also were aware that several external requests were likely coming our way as well. But we wanted to get that process started immediately because of what was happening out in the community. And so that's one example. Most of our NCDs are because of external requests. And if you look at an NCD and you go to the tracking sheet or the cover sheet of it, there's a link of, is it open because it's an internal, like CMS wanted to do it on its own, or was there someone who requested it? And it will have a link to the letter, and the requester requested us to open up that NCD. So, and there's a lot of nuances in there, but that's in general how we handle most NCDs.
Thanks. And does CMS take into account costs to either the Medicare program or otherwise into account in its national coverage determination process, either deciding to open one or as part of the process?
Once we open up a national coverage determination, cost does not come into play on making a decision on whether something is covered, non-covered, or under what circumstances something might be covered. That is a long-standing policy for CMS, and we have never taken cost into account. Now, there is an exception to that, because Congress wrote in the statute that we can take cost into account for certain preventive or screening services. So that is the exception, because it is explicitly written into the statute. And so we have commissioned technology assessment on certain screening services as part of the decision. But other than that, we do not take any cost of any for any device, drug, or anything when we write a national coverage determination. That is also true for local coverage determinations, because they use the same statute as NCDs. on whether something is reasonable and necessary. And so cost is not part of that equation.
Great, thank you. And then you mentioned the relationship between national and local coverage determinations. Could you talk a little bit about, where local coverage determinations come from and who's in charge of those and how they relate to national coverage determinations?
When there's not a national policy, whether that's a national coverage determination or it could be a regulation or other national policy, our local contractors are our Medicare administrative contractors, and these are our contractors across the country that process claims for the Medicare fee-for-service program. So if there is something that we have not nationally policy, then our contractors are responsible for processing claims and adjudicating those claims under the statutory requirements. And they can do this in a couple of ways. One is a local coverage determination. And so they have several local coverage determinations to do the same thing that we do at a national level, but they do it in their jurisdiction. So whatever that LCD says, then that's the circumstances that they would cover a particular item or service. If there's no NCD or LCD, which is the majority of things, then it's claim by claim adjudication, where you put the appropriate code and you put that on the claim and it goes through the system, and our MACs decide whether that is reasonable or necessary or not. Does it meet the statute? Lots of different reasons of why a claim can or cannot be paid. This does not mean that they pull every single claim and they review it. Most of them go through the system, but they may take a look at certain claims with certain codes to make sure those particular services are meeting whatever criteria are out there for those services to meet. Did I answer your question?
Yeah, great. Thank you. And you can imagine a lot of these questions are ones that we get all the time, and it's better to have you answer them. And so and it's nice when you say the same thing that I say. So even though you don't know you're doing it. So Jason, I'd like to ask about there's a lot of types of coding applications with a lot of, and payment applications. So could you tell us a little bit about, we get a lot of questions like, hey, I need a C code. Can you tell us a little bit about the different types of applications that are coding or coding and payment that your group processes?
Sure. And Jim, I think you're mostly referring here to the level 2 set. I think I spoke kind of about the hospital inpatient to some degree, but we do have some hospital inpatient requests for new procedure codes for ICD-10 that we do receive. But in terms of the level 2 code set, for the most part, level 2 codes describe items or services that are really not covered in level 1 and not really a dental service. The American Dental Association, the ADA, is responsible for the dental code set. And that's somewhat probably just a historical aspect of the fact that Medicare at the time that it was establishing level 2 was doing a lot of the non-drugs and non-biologics DME post items and services. AMA was already doing its CPT code set, and ADA was working on dental services, which, as many of you know, are for the most part not covered by Medicare. So that was kind of the initial division of labor, so to speak. We see a significant number of requests for new drugs and new biologicals that are typically a Part B drug. In other words, they're not self-administered, but they would fall in the Part B space where they would probably be incident to a physician service, well captured under 1927K of the statute, and are generally, but not always, but generally a single source drug recognized through the FDA approval process. And so as a result, those have a certain way with which Medicare in particular has an obligation to provide payment under 1847A of the Social Security Act. And so we have a pretty significant number of code requests that are for new drugs and new biologicals. Then there's a category that, for lack of a better term, we have just labeled non-drugs and non-biologicals. So that means that for the most part, that means that it probably has not been approved by the FDA as a BLA or an NDA, or at least probably not approved by the FDA for marketing by CDER or CBER, for instance. It's not a perfect description of what this is, but it's kind of a general description, is that it's for things that aren't drugs and non-biologicals. Now, it does include some areas that you might not think about, like ambulance services. We also do some support for the Medicaid program, whether that's sometimes a state-specific issue when a state is working on a waiver service, or something at a national service. We also typically do the products that are for home use, in which there is not a clinician service involved. So where it's not necessarily an incident to product or service that kind of accompanies particularly a CPT code in that respect. So durable medical equipment, prosthetics, orthotics, and some other supplies are generally well described in this level 2 code set. There are some other circumstances, as Jim was referencing, the C codes, where there is a pass-through application for hospital outpatient, for instance, in which the product or service is sort of not yet associated necessarily with a CPT code, or is eligible for pass-through payment. And so we identify that often with a C code. Not necessarily, there's some other codes that we can use or sometimes do use, but C codes are generally used to describe a pass-through drug or device, and in particular, the devices.
Thanks, Jason. And so just because an item or service has either a CPT code or a HCPCS level 2 code, does that mean that Medicare is going to pay for it?
No, it does not. There are a number of products and services that do not have a benefit category, but they may be something in which another payer, Medicaid, Veterans Affairs, VA, private payers can pay for, that Medicare does not have a statutory authority to pay for. There are also cases, as Tamara was describing, in which the product or service may not have been found to be reasonable and necessary, either through an NCD or an LCD, as Tamara was describing. And so in those cases, those products or services would also not be able to be paid for by Medicare. But those may all still have a code. And so a code by itself, in and of itself, a code does not indicate separate payment. But it's often viewed as getting a code provides payment, but it is not necessarily a one-to-one correlation in that respect. And also, as Jim was saying, at a certain point in time, some products, like those that may start with a C code for pass-through, at a certain point in time may become bundled as well when their pass-through period ends. And so again, the code doesn't necessarily confer that type of payment status long-term for Medicare.
Right, and thanks. And I noticed that, since COVID, there used to be a big HCPCS meeting, but besides that, it looks like now there's an electronic application and a faster review process than there was. Could you talk a little bit about some of the recent improvements in the HCPCS level 2 coding request and approval process?
Yeah, sure, happy to. Some of this started and was planned to begin in 2020, and so some of it happened to coincide with the pandemic, but not necessarily by choice, just by circumstances. So many things have happened that way in 2020. But it did allow us to accelerate a certain part of it that I can discuss. So we have moved to an entirely electronic environment. For those of you who would have been involved in filing with us in 2019 or before, or even very beginning of 2020, I think we actually requested 26 paper applications by a specific date. We've been able to modernize that. We're entirely electronic. We use a system called now Maris, which we've been gradually deploying. We are using it for a number of functions across fee-for-service and bringing different modules online. So we're accepting applications for our HCPCS coding entirely online through the Maris system, Medicare electronic application review or request information system. I think we had to find something that wasn't trademarked, and we wanted it to start with the letters ME. So there weren't a lot of choices by the time we narrowed it down to that one. So if you hear us describe Maris, we're describing that electronic portal. It is already helping us as well, and we think there'll be long-term opportunities for those who are submitters. It will allow you all to see your applications in a more combined way over time as the system matures. Hopefully, it does also keep the correspondence between us if there's questions or inquiries. We're keeping it as a data management processing tool. It also is easier for individuals to get into the same file at the same time, to do reviews, to look at a couple different files. If there's maybe a pending application for pass-through or new tech, we can kind of cross-reference those applications, and also easier for us to search and engage. And the other piece that we've done differently, we used to code on a once-a-year basis. So that meant basically you sent your application in, and about 10 to 12 months later, you would have a determination as to whether a code was available, would be made available. We do 4 times a year now for drugs and biological products, roughly a quarterly cycle. We think that this is typically shaved off somewhere between 6 to 9 months for a code to be issued for most drugs and biologicals. And we do a twice-a-year cycle for non-drugs and non-biological products. And the reason that we do that is that the statute does call for a public consultation engagement process. So we have twice a year, we have a public meeting in which we engage with the public to hear perspectives on preliminary coding positions that the agency is taking, and then final decisions that we would make are informed by that public meeting. Of course, in the COVID environment, we're entirely virtual now for that, which has a lot of benefits, maybe a couple of downsides, but a lot of benefits, I think, for getting that engagement. And for those who are following durable medical equipment DME posts, we issued a final rule that takes effect at the end of February. And in our public meeting process as we go forward, we'll also be bringing back Medicare aspects of benefit category determinations and payment methodologies that would be associated with new non-drugs and non-biological items and services.
Thanks, Jason. And then will there be trainings or instructions or anything like that on how to use the new electronic applications and things like that? Is that also part of the rollout?
So there is information that's available on the website. I think for the most part, it sounds like it's been fairly intuitive for getting access and getting logged in. And we do have a technical support contractor that facilitates that and can assist with that. And I believe there's also some sample applications that are up, templates that describe the information that's going to be requested. It's the same questions that if you've been submitting in a paper-based format before, it's the same kinds of questions and the same type of information, just in an electronic standpoint. So I think for the most part, we've been getting pretty good reviews, and most of our users, I think, are pretty tech savvy themselves and have been not expressing any undue difficulty. I would just say kind of like for those of you who have been involved in submitting, applications for, say, loans or FAFSA or, any student loans for college or something like that. Don't wait to the last minute to get started. Don't wait until that 11th hour before your college before that college submission is due, because you've got to click through the screens. You've got to pull together the information. You want to make sure that you're presenting a good quality product to us that we can review and consider. So we'll just encourage everyone not to get started on a few hours before the deadline that you were trying to make, or you might find yourself really working to the 11th hour to feel like you've got everything submitted.
Right. Well, so one more question before I go back to Tamara, but maybe could you say, you mentioned high quality applications. Could you mention a couple of common mistakes that people make in filling out the HCPCS application? Either they shouldn't be filing a HCPCS application at all, and why, or there's some questions that they just don't understand or provide a terrible answer to.
Yeah, there's a lot of variability. We definitely can see some variability both in the experience of the applicant or the experience of the company. Sometimes we do see what we're pretty sure someone said, we're not sure we're going to get one, but we wanted to ask for one anyway. I think that is something I hear commonly, at least informally. So I recognize that may be the position you're in, and maybe even advise some individuals not to pursue that. But the cost of entry was fairly low, I guess, in relative sense. Probably the most common is really when it's probably best described as part of a level 1 procedure code. Really, it's kind of bundled there, or would typically be a service or a product that would typically be bundled and used in that procedure. And so really, I think that that's something that a lot of time, I think, is sometimes spent engaging with CMS to really recognize that we're going to only offer a referral to our colleagues at the AMA and through their CPT process or perhaps the RUC process if it's kind of evaluation concern that someone has about a new technology coming in. And so I do often see entities sometimes spending 6, 9, 12, 18 months really engaging in the wrong door. And again, that sort of begins with that assessment of what is the correct, so to speak, the correct level for a code that describes the setting and the product. Another area where I would say I hope that we'll see continued strengthening from applicants is around other payer policies. We do have a lot of statements that are made to us, well, such and such pays for it. And then there isn't necessarily a policy that shows that such and such is paying for it. Or maybe it's a policy that might be under development, but not yet right. Or maybe there was a claim paid, perhaps on a kind of a claim by claim basis, but there hasn't been multiple claims paid. We really are interested, particularly for the non-drugs and non-biologicals, of knowing what other payers are interested in and what they are, especially if the product or the service has been established in the marketplace for a while. That's very informative to us. It is something that we try to take a look at, and it's something that we do especially try to tease out in the public meetings. And I think if you look at some of our preliminary positions that we issue, you'll see increasingly where we've said, can you tell us more about what other payers are doing here? And that may be because we are not certain that there's a Medicare approach. It may not, or it may just be so novel that we're not even sure what Medicare will do with it either. But those are really critical questions for us that I think sometimes applicants are only coming to us speaking kind of what they think Medicare should or shouldn't do. And we're also interested in what other payers may or may not be willing to do. And certainly open to hearing from other payers in that assessment as well. So those are two areas that I think often involve sort of excess work on either the part of CMS or the applicants, or lost time even to perhaps get to clarity on where they may be headed.
Awesome. Thanks, Jason. Let me get back to Tamara. So Tamara, I've heard a lot about coverage with evidence development. Can you tell us a little bit about what that's about, and is that a national coverage determination, or what is that, and what should we know about coverage with evidence development?
So the statutory authority for writing LCDs is 1861 A1A. It's the same statutory authority for national coverage determinations when we cover something that's reasonable and necessary, and we think the evidence is strong enough to do that. So for coverage with evidence development, which started or was developed, or the idea was thought about, was around 1999. And then formally a coverage with evidence development guidance document was created in 2005 and revised in 2013. So if anybody is interested, I would recommend taking a look at the coverage with evidence development guidance document. But in a nutshell, using a national coverage determination, we do not believe it meets the A1A threshold, because we think that there are evidentiary questions about the appropriateness or benefit, the clinical benefit of that particular item or service. And so rather than issue a national no for that particular item or service, we thought the best way to do that was support evidence development to fill those evidentiary gaps. And coverage with evidence development, so it really says that it's reasonable and necessary in the context of a clinical study that answers one or more or all of the following questions. And there, if you go on the coverage website, you'll see a CED webpage, and you'll see about 20 CED national coverage determinations and all the trials and everything that we support in that arena. Coverage with evidence development can take can be a lot of things. It can be something as simple as real world evidence and a claims analysis, or it can be something depending on where you are at in your evidence. Where is the evidence and what is it telling us? It can be something as restrictive as a randomized controlled trial, because there are some large questions that we have. We have done all of that. We have many examples. We have a couple examples of claims analysis. We have many examples of registries, and we also have a handful of examples of when we would require a randomized controlled trial. So there's lots of different flavors with CED, but the goal is to support evidence development for patients and their clinicians and caregivers, and not to say no. And so we didn't want that yes and no. We wanted something in the middle as well.
Great, thank you. And then I have a couple of questions that I'm not sure if they're for Tamara or Jason, but I'll start with Tamara. So there's been, during the COVID public health emergency, there's been some additional flexibilities extended that provide Medicare beneficiaries with access to, items and services that might not have been covered, outside of the pandemic. How do you have any insight into if they started on a new item or service, during the pandemic, and then the pandemic ends and they no longer be eligible? What's going to happen? Do they stop getting that item or service, or do they, or what? Or is that still being developed?
I think these are items and services that are already coverable. I think what we're referring to is we may have waived some of the criteria to be eligible for that, for the ones that I'm thinking of, and many of you can correct me. So it's a really good question, and that is something that we are carefully walking through to determine what's going to happen after the public health emergency. And that's not just about coverage, where we may have waived some of the only the clinical criteria for coverage, but I think there are a lot of policies across the agency that this could affect. So those things are being carefully looked at to make a determination on next steps. So I don't have a good answer for that today, except that it's being actively discussed and reviewed.
Awesome, thanks. And then another question that we get a lot is a lot of new technologies are apps for your phone. And I was wondering what are the issues that app developers, that even if they get cleared by the FDA with their app, should think about before seeking Medicare coverage, coding, or payment?
So I think, Tamara, I'm happy to start with this one. You can jump in if you want. I think the primary question here goes back to some of what we've been discussing on the call, is the question of the setting of use in the benefit category. To the degree that something is bundled, say, I guess, into your hospital inpatient stay, and you're given an app while you're in the hospital, I think that's probably covered under your hospital inpatient stay, and it's not sort of separately identified necessarily. I don't know that there's a lot of those out there, but there might be. If you're talking about something that's more for, say, home use, prescribed for home use, which I think is the scenario that we're seeing increasingly, there is not necessarily a benefit category that describes that. The closest benefit that most talk to us about at CMS is the durable medical equipment benefit, and that is not a benefit that was necessarily designed or been interpreted to cover apps. It's designed for things like, if you look at the statute, it specifically says iron lungs is one of the things that's durable medical equipment. That's about as far away from an app as I can possibly think in terms of the spectrum of home devices that the FDA is clearing for market. So definitely think about the setting of use, and in terms of the Medicare fee-for-service environment, think about the benefit category in terms of approaching that with CMS. That does not mean, of course, that other payers have the same restrictions, but that is the framework with which we have in fee-for-service.
Great, thanks. And so is it the durability? So it is interesting to me that Medicare only covers durable medical equipment, because I don't know why other medical equipment wouldn't be reasonable and necessary, but I know that it's in the statute. So is it the durability requirement that keeps apps from getting covered as medical equipment, or is there more to it than that?
Well, I won't say that these have been evaluated from a reasonable and necessary standpoint. So, I'm not going to say that there wouldn't be other types of considerations that the agency would need to undertake, but the durability is generally considered kind of that principal complexity there. I think there are some other complexities in terms of the way different developers are rolling out their products, subscription-based versus maybe more token-based, that are interconnected with things. But the durability is really probably the primary conversation. And it's not that Medicare has made up the durable medical benefit. Durable is in the statute, and so it doesn't say medical equipment, it says durable medical equipment, and then describes some examples of what those are with some other definition around that. So CMS does have an obligation to put some meaning to durable, and certainly from the longstanding statutory perspective, every time Congress has added something to the durable benefit or made amendments. It's been under that sort of construct of it being something that's, quite physical, has many years of lasting aspect to it, can be interchanged with another patient fairly easily, and is primarily a medical item in and of itself.
Great, thank you. So there's, if I'm hearing you right, there's no point in an app developer trying to argue on their HCPCS application that their app is durable and fits into the durable medical equipment benefit category.
I cannot think of at this time an app that we have identified as having a Medicare benefit category. And I know that some of you are probably familiar with some of the CGM apps, but those do have a durable component to them. There is either there's a kind of a token device, or in some cases, as our recent rulemaking described, it's interconnected or interrelated to the insulin infusion pump, which is in and of itself a durable item. So that's probably the other place I can think of, though I think there's also some apps probably associated with like CPAP devices or some other oxygen type of equipment or something like that may be out on the market. But again, those are associated with that durable item
Right.
that Medicare has a reimbursement for.
And so one more question on that, and that helps us out a lot. Thank you. For durable medical equipment, there's often, the durable component is covered by Medicare and paid on a 13-month rental or the other way. But then there's supplies associated with the use of that durable piece of medical equipment. For example, you said CGM. So the supplies would be the disposable sensors and transmitters. So is the app payable as a supply, or how does Medicare think about that?
So I don't think at this time we've got an app in that nature that's been treated as a separate supply. I think those are questions that we do hear. There is some possibility that the agency could consider that further. I think some of our analysis is also in regard to how much of that is kind of just a natural extension of the device itself and the management and control of that device, versus how much is it a supply that is sort of distinct and holistic. Those would all be some of the different types of things that we would have to think about. But the critical components, I think, of at least a CGM device are the measures that are coming out of the sensors, and then how that information then is read and interpreted.
Great.
At least out of the CGM devices by themselves.
Thanks. And Tamara, I've got a softball for you, but I want to just get it on the record. Just because my device or drug or diagnostic is cleared or approved by the FDA, does that mean that Medicare is going to pay for it?
Maybe. We pay for most FDA approved or cleared devices, but there are some that we have taken on for the reasons that we talked when we first started this call. We might have an NCD request because they want clear national coverage, or perhaps there are questions about that particular device that our contractors might have, which would limit it. So what they say about the FDA is they decide whether something is safe and effective. So it's safe and it does what it says it does. And then we take over, but they don't talk about place of service, who are the appropriate patients, guidelines, those types of things. And that's kind of where we might take over to decide, the coverage criteria for those particular devices.
Great, thank you. Because, one of the other things is that when their FDA approves something, but there's no Medicare benefit category for it, then Medicare can't pay for it, even though it's FDA approved, and it doesn't it doesn't matter that they got FDA approval. So we run into some of that also, particularly with the apps that we just discussed. And then, so now we're running out of time, but I noticed that there was a proposal, a rule for Medicare coverage of innovative technologies. It was taken down, and then if I'm following correctly, there was a commitment to do something about Medicare coverage of innovative technologies, but not what was in the rule. And now I noticed that there's some listening sessions. Can either of you elaborate on what's going on with MCIT?
I would be happy to hand this to Jason, but he'd hand it right back to me since my group wrote that rule. So yes, you, in general, you summarized it right. There was a final rule in January of, I might have the wrong date, 2020. It was delayed a few times, a proposal to repeal it, and then we finalized the repeal. In the final, when we repealed, and we had a lot of, and if we had more time, I'm happy to go through this. We had a lot of reasons for that repeal. And the number one reason is that rule was not going to be able to be implemented in the way everyone thought it could be implemented. There are a lot of things that needed to happen, and those systems were not in place. And so we need to get it right. And so what we committed in the finals that we would start more listening sessions to make sure we got it right. So the first one is February 17th. The second one is March 30th or 31st. I'm sorry, I can't remember, but it's all on our website. And I think in the Unified Regs agenda, there's it says that a new rule, which is called TSET, for the life of me, I can't remember what that stands for, but that's in the fall of 2022.
Awesome. Well, thank you both. So Jason, any final thoughts before we wrap up? And then I'll give it over to Tamara for the last word.
No, thank you. Just appreciate the opportunity to meet with you. Lots of familiar faces and names on here, and others that I'm sure we'll be getting the opportunity to engage with over the coming months and years.
Thanks, Jason. And Tamara, any final thoughts?
No, the same as Jason. Again, appreciate talking with all of you and the format and all of the questions. And so I'm hopefully we'll engage more and more throughout. Thank you, Chan. Transitional coverage of emerging technologies. I appreciate that. So hopefully we'll engage with all of you more and more as we develop TSET.
Great. Thank you both. Thank you both for your public service. I really appreciate the work you do. And it's really, I think, of a big value to everybody that was able to join today to hear straight from you and see the thoughtfulness and professionalism you both take to your positions. So thank you very much for all of that. And we look forward to keeping in touch. So thank you both, Jason and Tamara, and thank you everybody for joining today and to the Applied Policy team.